total fluid restriction was 1500 mils, 500 by IV fluid and 1 liter by parenteral nutrition. And this was aided by furosemide administration and every 3 hours with a target urine output of 4.5 to 9 mils over a 3-hour period. And the fluid and restriction and diuretic restriction was continued beyond the extubation for at least 24 hours post-extubation. The endpoints were successful extubation, that is, patient was alive and without reintubation at 72 hours. Secondary points were, of course, time to first extubation, weaning from both invasive and non-invasive ventilation, how many days they were free of ventilators, lengths of stay and deaths and etc. So, as I said again, we knew the beneficial effects of keeping a low fluid balance as far as extubation was concerned. The BNP-guided strategy showed very significant benefits in the intervention group, which was particularly so in patients with poor LV function or the LV dysfunction. Whereas those with COPD showed less likely benefits in managing patients with a protocolized or a BNP-guided strategy for volume reduction. Patients, of course, with renal failure are not included because this influences the BNP, renal kidney function or kidney problems influence BNP values. And if you actually look at the differences in the BNP-guided group, those with acetazolamide, I don't know how many of you do use it. We use it very regularly because of the alkalemia that happens in these patients or most patients, especially with COPD, where there is a lot of volume and retention of CO2, and that influences the pH management a lot. So acetazolamide use was very significant in those with BNP-guided therapy. And the cumulative balance, this is what is so interesting, minus 180 in the usual care, nearly 2 liters negative, cumulative. This is over the period they were treated in the hospital. So whenever you do have patients who are overstaying their welcome in the ICU, please do look at the cumulative chart. It's not just that one day 0.750 positive, next day was 500, so I'm happy. So look at it as an overall. Every day have a cumulative index of volume. So this was nearly 2 liters negative. Outcomes, time to first extubation, definitely better in the BNP-guided group. Time to successful extubation, whether it was reintubated or second time, again significantly better in the BNP group. Time to weaning from invasive and non-invasive, again significantly better. And ventilator-free days, much better. 12 days or 3 days less than the usual group. Complications during weaning about respiratory function, those who had to go back on assist control was much lesser in this group. VAP, much lesser in the BNP-guided group. If you look at cardiovascular function, need to fluid losing was much lesser in the BNP-guided group. So just by implementing a restrictive strategy based on a particular value of a biomarker in these patients made a big difference to the outcomes of these patients. So this protocol decreased the fluid balance and duration of weaning without increasing adverse effects. So that is what is important for us. Anything which will not add to the morbidity of our patients, an important strategy for day-to-day change or implementation in clinical practice. This is compared with physician-guided fluid management. As I said, there was no significant difference in the mortality or length of stay between the two approaches. So essentially, I thought I would just restrict myself to a few topics, all evidence-based, to help us to make better decisions in our day-to-day practice and, of course, hopefully make a difference to the outcomes of our patients. Thank you very much.
Thank you, Dr. Gopinath, taking us through a tour of critical care articles. How do you decide which article to take to follow?
Oh, I know that was a very difficult task actually, but basically I thought I would have screened about 100 articles before I chose or zeroed in on these. It was essentially because they're all implementable. What I'm saying is they're all things that you don't, even a definition as I started with, it makes a big difference of how you categorize how severely or less severely ill a patient is. So that was my premise of starting with the change in definition, but most in critical care practice now use the Berlin definition anyway. The other was something routine as clinical fluids, fluid management in the critical care unit. What we normally search for, rather we have now stopped stocking saline or using saline except for for our heparin is saline flushes, so most of it is in lactated ringer. We don't have plasma light because it's a little expensive. Pardon? Yes, it would definitely apply. I mean, that's why I showed you that additional article of non-cardiac surgical patients by McCluskey in this month's article of anesthesia analgesia. They're all patients who came from the theater to the ICU. And they are the ones with definite hyperchloremia, which is up to 22%, and all of them had poor outcomes. And again, those two articles from Annals of Surgery that I showed were patients receiving observational study of 30,000 surgical patients, perioperative chloride use, poor outcomes, or more renal dysfunction rather. So these are the ones which we can easily implement in our day-to-day practice and make a big difference to the outcome. The elderly, the critically ill, renal function or altered renal function is one seriously significant factor for mortality and morbidity. So anything which can avoid it, which is as simple as changing the fluid practices, very important. The same thing, as I said, sedation. We all use tons of it. Patients are jumping off, they're chugging away like steam engines on the ventilator. You're talking about dysynchrony with the ventilator. So you keep on doling out, more opioids, more benzodiazepines, or sometimes even to the extreme practice of paralyzing them if they are uncomfortable. And in places like ours where we have postgraduates, their only task for the night duty is, I don't want to have problems. So just without your knowledge, they would have quietly given them a dose of muscle relaxant. Sir, everything all right, sir. All night, all patients are all right, except that next day morning, chest X-ray bad, everything bad, gas is not good. So these are all things that, as I said, so easy to implement. Change is something which we are resistant to, but I thought I would present some articles where change can be far more easier to implement without any hassles at all. Less hassles to everybody. Stop stocking saline, the nurses are happy, technicians are happy, one less to account for. And I know the BNP values, BNP costs a little, but if you look at the terms, in terms of the number of days they have spent on ventilator, I guess, thank you. That's asking me to shut up. Thank you so much.
BNP is for cardiac function?
No. Any fluid, volume overload, whatever the volume overload, it's just RV, RA, dilatation, volume load, preload to the, without even, you do any of, that's what we are doing right now for a critical care student. This is just for ordinary patients who come for overnight ventilation to us. Long surgeries, hypothermia, elective ventilation with oncology surgery of the airways. We just do a BNP value, and lo and behold, they would have received resuscitation, so much of volume, and all of them are high. The next day morning, we just give them a dose of 20 to 40 of furosemide. All their values are down and ready for extubation next morning.
Any question from the audience?
Dr. Gopinath, regarding ringer acetate versus ringer lactate.
Yeah.
Now that ringer acetate is available, have you found it?
No, as I said, no, we have not got it with us. Stereophundin is something, when we are working in a government hospital, so unless it's in the rate contract, I don't get to use it. But yes, acetate as an additive is much superior to lactate, because again that contributes to the metabolic part. So acetate also becomes a substrate for energy. It's supposed to be much superior.
No more questions?
Thank you very much for listening patiently. I hope you change your practices, please.